and welcome to HT's weekly talk show, The Interview. With Omicron disrupting life, it is time to ask questions yet again. How bad is it? Is COVID here to stay? What is the road ahead? And will masks be a permanent part of our attire? To ask and answer all this, we bring you a two-part series on the new variant, what science says and what the stars say. In the first, we speak to eminent doctors on the road ahead, and in the second, we speak to well-known astrologers on what destiny has in store. So, here is the first of the two-part series where doctors take us through the new variant. Welcome to the show, Dr. Anjali Mishra, Dr. Sudhir Tripathi, Dr. Harsh Mahajan, and Dr. Vinay Sabharwal. And thank you for being here and sparing time to dispel doubts on Omicron. Let me begin with Dr. Anjali Mishra, not because there is gender affinity, but because testing is the first and the most important. And without a test, nothing can happen. So let me ask you, are the current tests adequate for detecting Omicron?
Um, Thank you, Kumkum, for having me here on this show today. So, let me tell you that so far, the current tests that are available are definitely adequate for testing Omicron. What has happened with Omicron is that this is again, after this alpha, beta, delta, now Omicron, there has been a maximum mutation in Omicron. And this mutation, more than 30 mutations have happened in the gene that is making the spike protein. Now, when we are testing for, when we are doing a usual RT-PCR, what we are doing is that we are testing for various segments of the gene of the virus. And most Omicron has shown a change in the gene that is making the spike protein. Now, most tests so far that are available are testing other segments also. Therefore, it is easy to detect Omicron with the current testing that we have. So, to answer your question in short, yes, the kits available right now are capable of detecting Omicron with the same sensitivity and the specificity.
While on kits, I want to ask you something which everybody asks. How much and how effective is testing with these home kits? Is it accurate?
When we are doing the testing of the home kits, in the home kits, what we are doing is that we are testing the antigen. With the antigen, which is the effect, the protein that is made by the genetic material, it has to be in adequate amounts for us to be able to detect it. And we know that these home kits, if the viral load is low, these home kits will just show about a 50% positivity. The people who have a lower viral load will not show up in these kits. So the home tests are all right for, when you're doing a survey or you're doing a door-to-door kind of a point of care testing. But for a definitive diagnosis, I would say that RT-PCR is still the gold standard.
Okay, while on that, some people say and ask me, and I also have the same question, isn't it actually academic whether I have a Delta variant or Omicron? The fact is, I have COVID. So, or would you say that from a patient's point of view, it is important to know the variant? After you answer, I will request Dr. Tripathi to add to it.
It is actually a bit of both, let me tell you. Um, it's very important also to know the kind of variant you have because, as you know, the different variants will behave in a different manner. For example, in Omicron, now the incubation period, which was initially about 5 days for Delta, is now shortened to 2 to 3 days. So our policies will keep continuously changing if we know what variant is, you know, infecting the person. So I think it's important to know what variant you have.
Dr. Tripathi, would you like to add to this?
It's very important to know clinically what is happening. But at the same time, I'd like to also state that though it is a mild disease, it also has a full spectrum of the full gamut of the disease. You have patients who are asymptomatic, you have patients who are hospitalized, and you also have patients who die because of Omicron. So whether they are dying because of Omicron and associated comorbidities is very important to distinguish because the Omicron and associated comorbidities such as diabetes or hypertension or coronary artery disease or cancer or whatever else the patient has, they can also lead to exaggerated response of the Omicron infection. And therefore, Omicron may be more severe in patients with these comorbidities. Therefore, it may behave akin to the Delta virus infection in a certain subset of patients.
Dr. Tripathi, you spoke about deaths, and that was my next question. There are number of deaths which are happening in young people and children, and of course, India is the diabetic capital. So, talking of comorbidities, talking of young deaths, what is your take vis-a-vis Omicron?
There's some data from the United States which shows that about 40% of children, young children, have been admitted to the ICUs, and around 24 to 25% children have sort of succumbed to the illness.
What about data from India?
Data from India is still emanating. I think it is still early days because though we had the peak already in Delhi and Bombay, and it's coming down now, but the number of children affected are certainly more than what it was with the Delta virus.
Dr. Mahajan, talking of children being affected or infected, and considering you are, administering vaccination, would you say it is time for the government to really open it up for kids and younger kids? Or have we been too late in doing that?
This is a very important question that you asked, Kumkum, and this is a question being asked by parents as well. You cannot just vaccinate based on no evidence. So the safety of the vaccine has to be demonstrated first in a subset, in a particular age group, and only then can you start vaccinating. I don't think we have been late or slow. We cannot actually venture into this field without adequate data of safety and effectivity and efficacy. And when the time comes, it'll happen.
Dr. Sabharwal, are you seeing cases of children being admitted to hospital or coming with infected with Omicron?
We are seeing children being admitted or coming to hospital with Omicron positive. Last night, as I told you, we had a mother, a lady with two twins of 2-year-old age. They have been admitted with the positive Omicron variant. The mother was vaccinated, and the whole family is vaccinated, and they are admitted now. But we've had one more child of 3 years who was admitted a few days back, but with very mild symptoms. Most of the admissions that we are having in the hospital are of people who have either have had just one vaccine or are unvaccinated. The people who are getting admitted are mostly are of old age, having diseases like uncontrolled diabetes, hypertension, low immunity, and because of cancer, HIV, etc. Normal admissions are very little. Earlier in Delta, we saw about 120% occupancy. These days, what we see is 10 to 15% occupancy. Although we are seeing a lot of patients in the OPD, positive cases, but they only have flu-like symptoms. They are not indicated to be admitted.
So would it be right to say that during the second surge, hospitals were full up, OPDs were empty, and this time around, OPDs are full and hospital beds are empty?
Yes, OPDs consults are full, thanks to government policy of having online consults, which is being very, very useful in this time. Most of these can be consulted on telephone and can be treated. And if the patients keep in touch with the doctor, treating doctor, it helps a lot. He knows the severity of the situation and advise admission as and when the time comes. But OPDs are, yes, we are having OPDs. See, in Delta, we had a lot of emergencies. Our emergencies were full. People were coming with breathlessness, SpO2 fall less than 90, 91, old age, comorbidities, and there were a lot of hue and cry for the beds, which is not there now.
Dr. Tripathi, talking of comorbidities, do you think the Omicron variant has greater risks for those who are either diabetic or, as Dr. Sabharwal said, heart patients and with comorbidities? Or would you say, even if the symptoms are mild, the risks are also less?
No, I think what you say is absolutely correct. When a patient comes with Omicron infection or even the Delta virus infection for that matter, right from the beginning, all the COVID-19 patients have been prone to increased risks of mortality as well as morbidity because of diabetes and other comorbidities, which include things like hypertension, coronary artery disease, cancers, lung disease, etc. So, in diabetes in particular is a disastrous recipe for a COVID patient, including the Omicron patient. In fact, it is known that all those patients Omicron who have associated diabetes or other major comorbidities are likely to have a worse prognosis compared to those who do not have comorbidities. So managing the comorbidity is very important. If your diabetes is controlled, then you should have no problem with the Omicron or even the Delta virus earlier. But if you have a patient who's uncontrolled and gets hospitalized with the virus infection, then he's prone to all the risks of diabetes as well as the viral infection. And therefore, that increases the mortality. Also, the lung is prone to more infections because of diabetes. Similarly, a hypertensive patient has also got a similar risk profile of a diabetic. Hypertension, diabetes, they all affect the heart, they all affect the kidneys, and they all affect the various blood vessels of the body. Therefore, a patient with diabetes or hypertension is prone to all the complications of viral infection and that will not be seen in a patient who does not have diabetes. And that is true for coronary artery disease also, because in that case in particular, they already have compromised cardiac function. They may be in cardiac failure. So, if a patient with cardiac failure gets to a hospital or respiratory failure, they already have compromised lung status, cardiac status. Therefore, they have more risk of dying because of the viral infection.
My next question is something which I will put to all of you one by one. And, scientists are talking of several other waves of Omicron. So, where are we headed? There was a second surge and now the third. So, my question is, what was, what is, and what will be? And let me again request Dr. Anjali Mishra to begin with this.
Great question, Kumkum. Nobody really knows the answer. Normally, what happens is that there are multiple waves, at least 4 or 5 waves in any of these pandemics, and then finally the pandemic dies. This is exactly what happened with the Spanish flu, and we hope that it is going to happen with the SARS-CoV-2. But the point is that how it's going to happen, how many mutations are going to happen, which mutation is going to be how lethal, and how the transmission will occur, I don't think anybody knows. So I think
Dr. Mahajan, Anjali says nobody knows. Do you know? Do you have an inkling?
It would be foolhardy, to try to guess, and Anjali has said it absolutely rightly. No one knows about this particular wave. You may be able to, predict about certain geographical locations, say for Delhi or Mumbai or India. But globally, what is going to happen, no one can predict, especially in the unvaccinated parts of the world. That is where many of the mutations are occurring, will occur. Which one of them will actually become a variant of concern, only time will tell. And that's why it's very, very important to vaccinate everyone. What we need to develop in the future is specific vaccines, maybe targeted to Omicron or the newer variants that will come, which will also reduce the infectiousness, also reduce the transmission. The vaccines that we have today have failed against reducing transmission. They have succeeded in reducing severity of the disease. So we need the vaccines of the future, which are more wide based. One bottom line is, please follow COVID appropriate behavior. And with the Omicron variant, double masking has more or less become a must, especially in congested areas where there are a lot of people. And we need to follow that, so that lesser and lesser people get infected.
Dr. Tripathi, what was, what is, and what will be? And in the context of what Dr. Harsh Mahajan said, would we live for the rest of our lives with masks?
That's a wonderful question, and I don't know whether I have the right answer for that. So, what was, if I remember, it was in December 2019 when the COVID crisis broke loose, and all hell broke loose after that with the Wuhan virus. Following that, the second outbreak took place in 2020 and 21, and that was also disastrous. The Delta wave, which came, the second wave, crushed India. It was like a nightmare, and we do not want to live that nightmare again. So that's for sure. And the third wave, which has come, the Omicron infection, is milder and has not caused such great degree of devastation. But the future is still wide open. I do not think we can predict what the future is going to be.
Dr. Sabirwal, in your hospital, what kind of caseload are you seeing this time? And would you say that you can breathe easy, or are the challenges greater even if the infection is mild?
No, there are the challenges are the same, Kumkum, but yes, it is much milder. And adding on to what everybody said, that I am quite hopeful with newer vaccines, with boosters, with nasal vaccines coming in. We are going to increase our vaccination programs, and yes, Omicron will stay, but it will become milder and milder. And we hope if we take all the precautions, I'm sure we will see the end of COVID one day and will be without the masks. Because, see, we have seen the trend. It was in 2019, 2020, then now, third wave, it's much milder. The trend, I feel, is making us hopeful that a day will come in this scientific world when newer vaccines come, which are specific to transmission and virulence. We should be able, we can't, difficult to believe that one would live with this. I am quite hopeful.
Dr. Mishra, Dr. Sabirwal used the word "a day will come." To me, that's a long haul. Do you think we will have to wait for that day to come, which could be whenever, or is it around the corner that masks and this life the pattern which we follow would change?
Again, a very difficult question. And my answer is again, I don't know. That day will come. I'm still hoping for it, but we don't know when it will come.
Dr. Mahajan, please educate us on nasal vaccine. A lot is being said about that. How accurate would it be? How practical is it? Just take me through that.
See, there are trials that are going on with the nasal vaccine, and probably the Bharat Biotech vaccine would be available very soon. And one, it is much easier to dispense. People are much more likely to accept a nasal vaccine as compared to a vaccine where an injection has to be given. Thirdly, if we talk of the science of it, since these are respiratory viruses and they enter through the nose and the throat, local injection or spray in the nasal cavity, it is presumed and believed that that may actually lower the transmission also, because the initial cells that get infected are in the air passages, and that's where locally this vaccine is being given. So it is thought that it would lower the transmission, being able to kill the viruses right within the respiratory passages itself before they enter into the cells and into the bloodstream. So it would be very, very useful, and hopefully the day is not far that we will have wholly indigenously developed nasal vaccine, and especially for children, it would be a boon. And then it can also be dispensed probably off the shelf. I think it is time that it should free marketing of these vaccines should be allowed. They should be available with the chemists, so that we have a huge single doctor clinics within the country which are able to reach far and wide, even in the rural areas, the smaller towns. And this is how a part of the vaccination, especially in the pediatric age group, in children, happens.
My next question was, when would we be in a position to buy vaccines off the shelf and be spoilt for choice, as they say?
I think the day is not far. Of course, our choices may be limited to begin with. Two vaccines which have shown efficacy, effectiveness, safety would be available off the shelf, but with a prescription. Ideally, user should not be able to buy these. It should be the doctors who have them in their clinics, and they are the ones who should be able to give it. I think the government is seized of the matter, and the day is not far.
Dr. Savarwal, since vaccines are administered in your hospital, would you agree with Dr. Mahajan? And the other bit, there is a concern about malpractices. And when Dr. Mahajan spoke about smaller clinics, I have known cases where people have gone and administered vaccines at home and also given certificates, which I don't think is really allowed, or if it's a malpractice. Would you just throw some light on that, Dr. Sabharwal?
I would agree that is the ideal situation, that it should be available in smaller hospitals, small single doctor clinics. But what we have seen in the medical practice, and Dr. Sudhir might agree with me, that what happens is a patient goes to the clinic, small clinic, and most of the time, many times actually, he is attended by a compounder or by a nurse. Now, they will be injecting the vaccinations, which I think cannot be controlled by anyone, particularly in a smaller town. It has brought to my notice that a lot of people are misusing vaccination program. It has to be a controlled program. It should not be free for all vaccines.
Dr. Tripathi, would you agree to what Dr. Savarwal is saying? And the other concern is that during the third dose, for instance, many people said, how do we know? Are we getting an expired dose? कहीं वो हमको expired तो नहीं लगा रहे हैं? Those concerns, how can those be addressed?
Like Dr. Sabharwal said, having a compounder administer a vaccine, which is malpractice, which should not take place. They can administer the vaccine, but under the guidance or supervision of a doctor who can, and also the patient has to be monitored for 30 minutes for any adverse effects. And we know that adverse effects can happen. That has been seen with all vaccinations, and you have neurological adverse effects. You have a syndrome called the Guillain-Barré syndrome, which occurs following vaccination. So you must be on the watch out for these vaccination-related side effects, and that's very important. So having said that, I would say that this privatization is important. That would increase the reach. As Doctor has said, the rural areas are going to be affected soon. The tier 2 and tier 3 cities are going to be affected. It's moving from Bombay and Delhi to the other cities. So once that happens, the wave of the infection is going to continue, and that should be tackled on like a war footing.
Dr. Mahajan, how real is this threat or fear of of an expired dose being given, and how can one safeguard?
I think as the system is today, that fear is overstated, because every dose that is given has to be uploaded on the COVID app. And there they also know what is the batch number, which are the doses that you bought. Everything is there. I would agree with Dr. Sabharwal that you cannot have all and sundry dispense this vaccine, especially during these pandemic times. But I think the very fact that vaccinated people are well protected shows that the cold chain has been maintained throughout. So, to answer your question, I think this expired vaccine and all that is more of hoopla and is not a reality, at least till the present point of time.
That's good news. Dr. Mishra, let me come to another point. Low testing and no testing means low numbers. Is it a ploy to keep numbers down? And is no testing medically advisable? And what about asymptomatic patients then?
I would say that I am not, in favor of no testing and low testing. I would say testing is extremely important because that is the way how we contain any epidemic. We need to test, we need to have contact tracing, and then we need to put a stop to the transmission to the disease. We cannot be an ostrich and just put a head, neck down into the sand and say everything is gone away. It is there. It has to be dealt with. So I also believe that all these home tests that people are doing, there's no harm in doing these home tests. It's a good idea to do these home tests. At least the person is aware and isolates himself and may not transmit the disease to another person. So the chain is cut down over there. So testing is extremely important. It's time to choose what kind of test we want to do now. When we are doing an RT-PCR, it takes a whole day, the results come late. So maybe in the community, a rapid antigen testing may be a good idea to continue and to isolate these people who are positive and to stop the transmission of the disease further.
So, would you say that this is really a ploy and more a political decision to keep numbers down?
That's a very difficult question, Kumkum. I would refrain from, sort of giving my comments on it. I wouldn't be able to know what is really happening.
Dr. Mahajan, you normally give your views very frankly, so let me ask you, is this a political decision to keep numbers down?
No, I think it is not solely a political decision. After all, the ICMR has brought out this, advisory, and it's an advisory. It's not a directive. And there are very, very enlightened scientists who are behind this decision. We have to remember that the number of tests available in any country are finite. And that's where you have to prioritize as to who should get the test first. And that's where, if you remember, during the Delta wave, all and sundry were getting tested. And because of that, those who were actually sick were not able to get tested. So I think this is an attempt at prioritizing who is able to get the test first. The other, premise, I would think, behind not testing the asymptomatic who have come in contact with a positive is that these people should go and quarantine themselves. That is the premise. So this is where the government or ICMR expects that citizens of the country would be responsible. And if you've come in contact, you go quarantine, don't take away a test from someone else. Then one area where I do have a difference of opinion with the advisory is where they say that asymptomatic people who are admitted in hospital for surgery, for some other disease, that they should not be tested. I think here I differ with the advisory. I feel that anyone who's entering a hospital, even if having no symptoms or signs of COVID-19, must be tested, because within hospitals you have people who are sick and their immunity levels are down, and Hence, if you have an asymptomatic carrier who is in the next bed to you, you are likely to get the infection because this is a highly infectious virus.
Dr. Sabirwal, would you agree with Dr. Mishra when she says testing is a must? Or would you go along with what Dr. Mahajan says that prioritize?
It's a mixed reaction. I would say yes, testing is very, very, very important, especially people having symptoms. We must test. We should not ignore and pass it off as a flu. I would agree with Dr. Mishra more that testing is very important. And Dr. Mahajan said, yes, uh, it's a hospital policy that we test all the patients before the surgery, which is very important because because when we do the surgery, it's a aerosol transmission. Patients are given anesthesia. Many doctors, hospital staff is in close contact with the patient, and in case he's positive, that means the whole clan, the whole hospital can get infected, and the patient, the wards can get infected.
Dr. Tripathi, there is an attempt to redefine deaths, if I may use the term, which means that those COVID patients who have comorbidities and unfortunately did not make it, they are being categorized as deaths from comorbidities rather than COVID. Now, is this mere jugglery? Is this, or is there some truth in this?
Well, I think it's. I'm not sure what the intention is, but the fact is that when a hospitalized patient dies, he dies of corona infection, whether it's the Omicron variant or the Delta variant. He's classified as having a death because of COVID-19. On the contrary, if a patient dies because of the underlying disease which is predominant, for instance, if he has heart failure, he comes with heart failure, he has coronary artery disease, ejection fraction is very low, that's the function of the heart is very low, and then he has superadded corona infection and he dies subsequently, then that primarily can be attributed to the coronary artery disease or to the heart failure. However, if the corona infection is the predominant reason for admission, and that is often the case in these patients, if they have coronavirus infection, he has corona pneumonia or some other multi-organ dysfunction, then the death should be primarily classified as being because of COVID. But it's a very thin line of differentiation. The primary treating clinician in the ICUs or wherever the patient dies or passes away has to make this distinction and give the right data so that the statistics are correct. Because statistics are very important in the future planning also. If you have a patient dying of coronavirus, mortality is high because of coronavirus, then you know what to do next. But if you sort of fudge the figures and say that he's died of the comorbid condition, not because of coronavirus, then you think that it's a very mild infection, you take it lightly or be complacent. You cannot be complacent with this infection. So this jugglery may happen at times, but I think the primary clinician is responsible for giving the right diagnosis at death. That will help in sort of managing the patient in the future as well.
Dr. Mahajan, there are also twists and turns in the vaccination program. Sometimes the government says 9 months gap, sometimes 6 months, sometimes 6 weeks. Now it's 39 weeks before between the second and the third dose. Is there any scientific basis for these parameters, or is it to fit in the problem of vaccine shortage and when vaccine is available?
I think it's a bit of both. One, we have learnt as we've gone along. As healthcare workers, we got our second dose after 4 weeks. Then it was tweaked to 6 to 8 weeks, then became 3 to 4 months. And over time, we've learned that yes, there was some science behind it. You get a more robust immune response after a 3 month gap between two doses of Covishield. Whereas for Covaxin, it's been 4 weeks from day one. That science has not changed. Now, as regards the boosters, uh, in England, they are giving a booster dose at 3 months, after 3 months. And in India, it is after 9 months that the government has decided that a booster will be given to healthcare and frontline workers, and to those above 60 years of age with comorbidities. 89% of India has received Covishield, and so 89% of India, as per government guidelines, is going to receive the same vaccine. Now, the same vaccine, I think there is a capacity constraint. I think because of capacity constraints, we within the country do not have a choice right now. We may soon have the protein subunit vaccine, which is being manufactured in India by the Serum Institute, uh, Covovax, and there is also Corbevax, another subunit vaccine which may become available. And then probably the guidelines may change. But right now, we have no choice but to get the same vaccine.
Dr. Sabharwal, do you think it was right and sensible for the government to delay booster doses, or do you think this is one of the reasons for numbers going up?
The boosters should have started, especially in healthcare workers, earlier, because worldwide they are giving boosters to all, whether they are healthcare workers or otherwise general population. I feel that we have delayed it because in our own hospital, I have seen there are a lot of healthcare workers who have suffered.
Dr. Tripathi, do you agree with Dr. Sabharwal?
I don't think we are late, very late, because the rest of the world has also started similarly. And except Israel, I think Israel has also gone in for the fourth dose of the fourth vaccine, which is the second booster. So similar data should emanate from India as well. And we also need to go in for the third booster as well as the fourth booster required.
Dr. Mishra, let me conclude by asking you three top of the mind questions. When should we be tested? When should we be retested if found positive? And are there any blood tests that can be done to predict the severity of the infection?
So the first question is, when should we be tested? So we were earlier saying for Delta variant, we were saying to test between 5th and 7th day, because the median incubation period of that virus was about 5 to 7 days. But here with Omicron, the median incubation period is much smaller now, and we should test people, on the second or the third day. And who should be tested? As far as my personal view goes, I think all contacts should be tested. It's important to prevent the spread of disease, because once you know, that's the way or every epidemic is dealt with, or every pandemic is dealt with, that you need to know you need to do contact tracing, you need to know what is the status of the contact. So that is the second part. The third part is, do you test? When do you test the person again? Actually, there's a lot of directive and advisory that there is really no need. After 7 days, in case of Omicron, the person can go back to work. There is no need to retest as far as this is concerned. Any case, if you want to retest, it is best to do it after 7 or 8 days. In spite of that, there will be a 15% who will continue to show the result. I mean, show a positivity in the test, the RT-PCR test. But one must remember that these are not infective. They are not capable of, transmitting the disease. The third question that you asked is, are there any ways by doing a blood test that you can predict the outcome of, the disease, the infection? So yes, we know that it is because of the cytokine storm that all the complications of COVID-19 occur, the pneumonia, the thromboembolic phenomena. So there are certain inflammatory markers like interleukin-6, ferritin, D-dimers, which can be done periodically, time to time. And if these levels are high, then one can predict that the outcome is going to be a little bit more adverse. Uh, but again, who to test is very important, because now with Omicron, one is not really seeing a very severe disease. So testing has to be again dependent on the clinical symptoms and how the patient is. Uh, but as Dr. Tripathi said, people who have comorbidities, who have a underlying disease, they should definitely undergo these tests, because one gets an idea of what is going to happen next, and one can intervene and treat accordingly.
Dr. Harsh Mahajan, Dr. Anjali Mishra, Dr. Sudhir Tripathi, and Dr. Vinay Sabarwal. Thank you very much. Thank you for your time. And thank you for being here and educating all of us. And don't forget to tune in for the second part of our series on Omicron, where we will talk to astrologers to find out what the stars have in store for us.